All right. Welcome, everyone. I'm Kathy Haung, the director of Endometriosis Center at NYU Langone Health, and thank you so much for joining us tonight. We have a wonderful panel of these amazing women who is going to join us in the conversation, and our conversation is just about how pain is not normal, and we need to stop telling people that pain is normal. So it doesn't even necessarily need to surround endometriosis per se, but the one message we really want to get out is that pain is not normal. So I really just want to thank you guys for joining us and thank our wonderful panelists for joining us. So Jennifer, would you mind introducing yourself and telling us who you are?
Sure. Hi, I'm Jen Duffy. I am a patient of Kathy's. I had excision surgery recently in December of 2020, and I was diagnosed with endometriosis about 17 years ago. I think I was 23 years old. I just turned 40. And I've spent the last probably 5 to 10 years seeking out ways to heal myself and not have pain after suffering severe pain and eventually being diagnosed with stage 4 endometriosis. So I'm happy to share some info with you guys today. Thanks for being here.
Thank you. Sallie?
Hi, I'm Sallie Sarrel. I'm a pelvic physical therapist specializing in endometriosis, and I'm a person with endometriosis. I went more than 23 years without diagnosis of endometriosis. So I did lots of things from pelvic physical therapy to diet, exercise, acupuncture, and even sweat lodges, don't ask. But I also endured more than 9 surgeries once I was diagnosed. I had my fertility taken when I had organs removed without consent. And wanting to put an end to the gaslighting and misinformation that drives endometriosis, I partnered with Dr. Andrea Vidali to form the Endometriosis Summit. And what we thought would be a small project, we are now one of the largest endometriosis patient and practitioner entities in the United States, with 1,000 people attending this year, our 3-day conference. So I am super excited to be here and to talk about pelvic floor physical therapy, and in a way that doesn't just talk about the muscles, but that talks about how your body can relate to pain. And I'm super excited to hear some of our guests tonight because they approach pain and life in a very different way that we all need to learn about. Thank you for having me.
Thank you, Sallie. Nikki?
My name is Nikki Dunham-Hoshida. I'm a nurse practitioner now working in cardiology, but very recently was a holistic nurse for many years at NYU Langone Tisch, certified in pain management as well as holistic nursing. And I have special training in mindfulness, chair yoga, and I've gotten the opportunity to work with a lot of patients who have endometriosis. So I'm here to learn as well. Thanks for having me.
Thank you. We basically just really want to get Nikki back. We need her to come back because Nikki was running our weekly meditation sessions for our patients with endometriosis. And, we established the Endometriosis Center probably about 7 years ago. And the goal is a multidisciplinary team that deals with this condition. And while I only do surgery, I really believe that surgery, while excellent surgery is absolutely a mandatory part of the treatment, it is not the whole answer. And I continue to explore such as meditation, pelvic floor physical therapy, nutrition, acupuncture, partnerships with our radiologists for imaging, for diagnosis, for fertility specialists. And we really need to have these bigger conversations of how do we come together so we can help our patients individualize their treatment plans, that we're hoping 2 + 2 does not equal to 4. We're hoping that 2 + 2 can get to 8. So while we add all these other modalities to our treatment plan, we really want to get our patients to the best place possible. So I think we'll open tonight with Jen's story, if Jen would be kind enough to share her journey with us, and then we'll go from there.
At age 23, I was training for a marathon and I had an organ of some sort poking through the front of my shorts. You could see it. My running partner said, you might want to go to the doctor. And it turns out I had a pretty large ovarian cyst. And they said, you need surgery, we need to go in there. And at that point, they said, we don't know what it is. And so they went in and did surgery. My gynecologist diagnosed me with stage 4 endometriosis. I think at that point, I don't have the medical records anymore. And they said, you can do medically induced menopause. And I was 23 and I did not want to choose that. And they said, okay, you can go on the birth control pill. So I did. And I still suffered with pain until my early 30s. I had a surgery and developed a blood clot, and I could no longer be on a full estrogen birth control pill. And from there, my pain increased and it increased and it increased. And I started to really look for ways to reduce the pain. And I'll be totally honest, at a point, Advil and Tylenol wasn't cutting it. And even when I spoke to Dr. Haung before my surgery, I said, what can I take? What can I be taking? Because I had nights where I was vomiting in the middle of the night from pain during my period. I'm lucky that I did not have pain throughout my cycle, only during my period. And I went on a wellness journey at the same time. And I think I would describe myself as a health nut, and at this point, maybe even a biohacker. But I started with a Whole30 diet, an anti-inflammatory diet, and exercise. And then I got yoga and meditation. And, you just start to go down the path. And I got my body pretty healthy. My A1C was low, my blood pressure was great, all these things, but I still had endometriosis pain. And I don't remember the book I was reading, but it was this topic, which is that pain is not normal. And if you're having that much pain during your period, there might be something going on in your body. And so I started to seek out doctors and seek out information. And I spent many Friday nights, Googling and reading, and I'm on PubMed, and I don't have a medical degree. I'm a marketer, and just trying to understand. And before I met Dr. Haung, I met a gynecologist in Scottsdale. Her name is Courtney Hunt. And she's now into kind of cellular medicine and genetic testing. And I was already so far down the wellness path. I had genetic testing done. So I found out where I was predisposed to inflammation. I learned about whether I had some modifications on detoxification pathways, where my body was struggling based on my genetics. And I started basically lifestyle and supplements to support the health of my cells. And I started to feel better. And it was a little bit like magic, but it's actually science. It just feels like magic because I don't have a science degree. So I can say, one of my supplements has superoxide dismutase in it. And Kathy could tell you what that's about. I just know it's one of the things that helps, a pathway that helps me feel better. I think in my story, I was learning about surgery. I had been told several times I needed a hysterectomy. Just like I didn't want to go into menopause when I was 23, I still didn't want to go to menopause in my 30s. That didn't sound like a good option to me. So I turned that down. And I was Googling, I literally thought, who did celebrity surgeries? And I was looking around online and I found Kathy being quoted in a BuzzFeed article about another surgery, and I called her. But my story is, and I'm super curious to hear from Dr. Sarrel about, pelvic health and wellness, because I think so much of my path has been, I do yin yoga that focuses on the pelvis and the hips because I carry tension there. I know my psoas is tight. I'm curious to work with a pelvic floor therapist because I know I've got issues going on in there. And so I think there's just so many facets to this, and that's what today's conversation is about. But just the rest of my personal journey, I'm 4 cycles out of my surgery with Dr. Haung, and I'm in my lifestyle with supplements that support my genetic deficiencies, if you will. I'm not even using the right language, you guys. I'm really, not in the medical field that much. But I also live I'm in a metabolic state called ketosis, which is not a diet. It's a metabolic state. That's what my doctor in Scottsdale will tell you. And that's because there is research that state will reduce inflammation in the body. And for me, I've found that I'm prone to a lot of inflammation. That's what my genetic testing said. And so while an anti-inflammatory diet of whole foods and fruits and vegetables may work for someone, I had to continue to reduce inflammation for some reason. And so I'm in ketosis most of the time, especially during my period. I'm in ketosis right now during my period, and I'm pain-free. No Advil, no Tylenol, no heating pad, nothing. But I also sometimes use cold thermogenesis, cold plunging, to further reduce inflammation and also to induce autophagy, which is cellular cleaning, which happens when you sleep. Dr. Kathy's more qualified to talk about this than I am, but I also use intermittent fasting, which also induces autophagy. What I learned was I just need to get inflammation down in my body, and I need my body to be able to detoxify itself. And for some reason, that takes me out of pain. So that's how I've worked. And I work with meditation, and that's sort of my story. And I think I had surgery, I had excision surgery in December. My MRI said that I was, likely my uterus was fused to my bowel, and that was pretty bad. And I still chose to have surgery as well, because my goal was to prevent, I'll be 50 in 10 years, that'll be maybe menopause. I don't want anything bad to happen between now and then. And I just want every possible way to give my body a chance to live and be healthy and not in pain. And I'm just so grateful to be pain-free. And I want that for you guys. And I want that for everyone out there. So I'm shouting it from the rooftops.
Thank you so much, Jen, for that story. There are two things that I heard that I have to say something. Okay, hysterectomy is not the answer. By definition, endometriosis is an extrauterine condition. So unless you have adenomyosis, where endometriosis invades the uterine wall, a hysterectomy will not help you. And I can go down a whole other rabbit hole about how we need to keep the uterus for many different reasons, and because it actually also alters your hormone. I certainly agree that a 23-year-old should not be in menopause. So I myself don't use any Lupron or GnRH agonists or antagonists. The other things that we really have focused a lot on is diagnosis, in terms of how do we use a less invasive method and imaging, either MRI or ultrasound, and not having surgery to diagnose someone with endometriosis. I think that's so extreme, and we have gone so far in technology that so we really need to be pulling it back. And what are the different ways that we can use imaging, not just to diagnose endometriosis, but when you have pain, you could have endometriosis, you could have adenomyosis, you could have fibroids. There are a number of different reasons, and we have to start there, right? We cannot start with surgery. That really just makes very little sense to me. But I'm gonna stop talking, because I really want Sallie to jump in and tell us about pelvic floor physical therapy, because I totally work with our PT folks. I even send the patients to PT before surgery, again, looking for this exponential benefit so that we can maximize between what we do and what other modalities do to give our patients the best outcome possible.
Thank you, Kathy. And thank you very much, Jennifer, for your story. And I think Jennifer's story brings up something that's super important to understand. And that's that even though she eventually had surgery and had the correct surgery by having excision by an expert who knows what they're doing, that there's multiple ways of attending to pain, and there's multiple drivers of pain. So while you may have endometriosis, your pain could come from the bladder. Your pain, I do a great deal of work in hernia and pelvic pain. Your pain could be driven by different genetic issues in terms of getting your nutrients to your bowel. And your pain could be driven also by the central nervous system. And your pain could be driven by muscles, bones, ligaments, and fascia. And so when you treat someone with endometriosis, it becomes really important to know that it's not going to be one thing that's going to fix everything. And Jennifer displayed that so beautifully in her story, because she was very responsible for herself, right? And so she wants to share that. And I think that's Dr. Haung, or Kathy, as she's asked us to call her, that's been her approach, is that these webinars are to share that there's more than one way to help yourself feel better. So with physical therapy, we know that if you hurt your shoulder, you would go to physical therapy. And actually, you would go to physical therapy even if they saw a tear on MRI, because you would do something called prehab. So that surgery would basically work better, and you would get back to maybe skiing or tennis, or in most people's cases, just sitting in front of the TV faster. And so pelvic floor physical therapy is a branch of physical therapy that requires training beyond our doctorate level education, where we can recognize dysfunction in the bones, ligaments, fascia, and muscles involved in the hips, back, and pelvic floor. And what many people don't understand is that the pelvic, it's not like I mean, I'm going to be real with you right now, but it's not like when you go inside the vagina, all that's there is vagina, cervix, uterus, ovaries. That's not the way it is. I have some pictures of people, if I can share screen, I don't know if I can. But when you go inside the vagina, there's a grouping, there's a superficial layer of the pelvic floor that's a ton of muscles that could actually prevent penetration, but it could prevent things exiting too, like urine and stool, because things go both ways. And then there's a grouping of the pelvic floor that is further back called the levator ani muscle group. And that could cause all sorts of pain, from tailbone pain to painful sex to pain with sitting for too long to a back pain. And so and also it could cause bladder spasms. It could make your cramps worse, because if your pelvic floor doesn't have any length, and it has to have length and strength to it, not just strength and not just length, but then you're going to be gripping in your pelvic floor. And so that affects your hips, that affects your legs, your low back, your sciatic nerve, your ilioinguinal nerve, which is like my favorite nerve in the body. And it affects basically the sacral nerve roots. And the sacral nerve roots get information from the bladder, the uterus, the ovaries, and everywhere. Well, not really the ovaries, and from the peritoneum a little bit. And so if everybody's sending a painful signal, well, guess what? Even after the endometriosis is removed, you're not going to feel better. So you have to send a good signal. So that brings me to what also happens is that once you have pain, the brain, not only do you have reactive spasms trying to protect you from the pain, because like if you touch something hot, immediately you're going to recoil. But when most people, their pain starts when they're 13, 14 years old. I've talked to people 9 years old. And so the reactive spasm starts then. And then what happens is the brain recognizes that feedback loop, and it's trying to control that pain more, and it sends another signal that makes that pain even worse. So then you go in and you have an expert surgeon cut out the disease, but guess what? They've done nothing for that feedback loop. And so that's actually, we're going to talk about mindfulness in a minute, but that's something that mindfulness can do excellent things for. But that's something that learning to move and learning to either calm your body or empower yourself to feel better can do a lot to interrupt that feedback loop. And then the last thing is, like, I see this all the time, and I had this because I had major abdominal wall reconstruction with abdominal wall endometriosis 2 years ago, and it took me 18 months to recover. And the reason why it takes 18 months to recover is not because you feel fine, you go back to work, I get it, fine. But 18 months to be able to hurl myself down a mountain and ski, and 18 months to be able to run 6 or 7 miles, and 18 months to be able to play tennis 3 or 4 days a week. So healing from surgery doesn't end when the incisions are healed. First of all, with minimally invasive surgery, you're healing inside for a while. But healing from surgery ends when you are living the life that you deserve. And I feel like pelvic physical therapy is one of the things that helps get you there, because you betcha if you had an ovarian cyst that was sticking through your abdominal wall, even if it was 10 years ago, or you have, ureter problems from the endometriosis, or you have uterosacral endometriosis, you have adaptations not only inside your pelvis, but throughout your abdominal wall, throughout your diaphragm, which is the top of the abdominal wall, throughout your rib cage. Now we're even seeing there are great courses on how breath and the throat affect the pelvic floor. And that is all changed. And then you take that into the endometriosis patient whose throat has been shut off because they go to the doctor and they ask for help and they don't get it. or they get the eye roll, or they get told that they're not telling the truth. And then you've internalized that pain, and then you're gripping here, which means you're gripping in your pelvis. And so all of these things after, if you choose to have surgery, and not everybody chooses to have surgery, but all of these things have to be attenuated to in order for you to live your best life. Not brief, but that is answering the question.
Thank you, Sallie. I do think there are so many different components to pain. And again, surgery can really only take care of only a part of it. And Nikki and I had this discussion so many different times that the body keeps score. And the things that have happened to you, whether it's emotional trauma, can also contribute to the pain. And that pain is very, very real. We do continue to work with patients with sexual trauma. We are really hoping to start a clinical trial, MDMA-assisted psychotherapy for our patients for endometriosis. What's even closer to is that we've been working on, Justin's on this webinar too, Justin, and shout out to Justin, our research coordinator extraordinaire. So we are working on a single blind study for IV ketamine for chronic pain as well, because it's such evidence that help dissociating with pain, with even treatment-resistant depression. Again, endometriosis is such a complex condition, right? It impacts your sexual wellness, impacts your fertility, it impacts your body in so many different ways. And so simply excising the disease is just not enough. So Nikki, you got to chime in now.
So yeah, thank you for that amazing introduction to this topic of mindfulness and the mind-body link. I've definitely learned a lot from the patients with endometriosis that I've gotten a chance to work with, but with this population and any population really, my focus is to be on what is right for that individual patient. So in the field of meditation, I think mindfulness is the most studied as linked to patients that have endometriosis. But again, it has to be individualized to each individual person. So if you are not the type of person that mindfulness is going to work for, and mindfulness is really the concept of just noticing something that's happening in the present moment. Maybe you're someone that wants to use their imagination, so you use guided imagery, or maybe you are more drawn to something that involves movement, and it involves running or swimming or yoga or even mindful eating. There are many different things that you can try, but it has to be based on what's personal to you and what works for you. And I think that's really what is the bottom line of this whole discussion, is really being able to help patients personalize their care for what's appropriate for them, their body, their history, and their interests.
I mean, I think there's just so much, right? In terms of, I get a lot of, I feel very sad when patients show up and said, I've been in pain for 7-10 years. And we know the average time to diagnosis for endometriosis is 7 years, and that's simply not okay. And I think we just need to stop telling people. I mean, certainly when I was growing up, I was told that pain is normal. So I just thought if I have back cramps with my period, it is normal. But we just need to stop saying that. This is not okay to keep telling people that. So, and it is not okay to have repeated surgery. I mean, to not have 9 surgeries that Sallie's gone through, there has to be a better way, right? So there has to be a better way. We cannot be doing surgery just to diagnose patients. And we were talking about this before we went live in terms of how we use imaging. We use imaging, one, to diagnose endometriosis or any other gynecologic conditions in this case, but also once we figure out if you have endometriosis, we need it for treatment planning. You know, if there is involvement of the colon or the bowel or the ureters, then we may need to have a multidisciplinary operative team right? So if I need to do a colon resection, I am not equipped to do a colon resection. And I do not want to find that out in the middle of the surgery and then have the patient under anesthesia and wanting to find whoever's on call to do the surgery with me, because that's, again, not good care. And if we have to be in that scenario, there are going to be times that we're left in that scenario, but that should not be what our routine should be, right? That should not be a standard of care. Our standard of care should be, how can we find out more information? Not only yes, no surgery. There could be medical options. Again, I'm not a huge supporter, just myself, my own clinical practice. I am not a huge supporter of giving patients hormones to go into a menopausal state for endometriosis. I just don't think people respond well to it. And I think gynecologists, I'm one of them, we really need to work across borders. What are the other implications of hormones? I don't think we fully understand that yet, right? So as I was saying before, if we do a hysterectomy for a patient with bilateral ovarian conservation, this is a 12-year-old study. Even if we keep both ovaries, we increase your early onset dementia risk by 38%. And if you know that, you will absolutely say no to, I mean, maybe you wouldn't absolutely say no to it, but at least I need to give you that information. And how does a hormone interact with the body? We don't really know all of the answers yet. So I think we should be more mindful of these different treatments, of what are the other ramifications that we don't yet have transparency to. We just don't know enough yet. So we really want to do least invasive form of treatment. How do we, work together? And Jen, as you were talking about autophagy, intermittent fasting, and I'm totally obsessed with Peter Attia. Again, there's no conflict of interest whatsoever, right? So I subscribed to his podcast. I literally listened to everything. I almost got a CGM monitor for myself just to know, like, am I in autophagy? How do I get into autophagy? How do I become in ketosis? So again, this is like a total rabbit hole that you can go down, but it doesn't work for everyone. And he says that all the time, right? Like, you need to figure out your body, and we need to own our own bodies. So there is some sort of personal accountability, and you don't need anybody else to empower you. It's your own life and your own body, and you want to take some responsibility for your health, right? So if someone's saying to you, hey, pain is normal, you need to find another person. Find someone else who's willing to listen to you and hear what you're saying and give you options that make sense to you. So, I mean, that's just sort of where I'm coming from. And that's why I think this is so important.
Yeah, I want to echo that. My issue is inflammation, because I have genetic testing that shows that certain genes have polymorphisms, and I know that my body has a problem with inflammation. My C-reactive protein was like 90. So it was high. I had tests that showed that my inflammation was high, but that may not be the case for other women with endometriosis. We don't know what causes endometriosis, but if I could empower women who can, and by the way, this was not genetic testing from the internet. It wasn't an ad from Instagram. It wasn't, there's a lot of that stuff popping up. This was an OBGYN in Scottsdale. Her story is that she saw a lot of sick patients and she wanted to figure out more ways to help them. And she went down the kind of nutrigenetics way. And so she launched a company, Genetic Protocol, that does genetic testing. And then you get coaching from her, an MD, on how to supplement for your specific gene. So I just want to put that out there. What works for me, and the ketosis and the cold plunging, talk to your doctor though. It may work for you. Dave Asprey's out there talking about, keto cycling, and a healthy diet is not going to hurt you. Now, how we define healthy, but anti-inflammatory, but I will say inflammation was for me, and I don't know what it is for everyone else, but it was a light bulb for me because I thought I had a diet that was supporting my body. And then when I removed a lot of starches, I instantly felt better. And I also have genes that show that I'm prone to insulin resistance, and I'm prone, my body reacts to sugars in a harsh way. So but that was the magic for me. And that's, I think, your point, Kathy, that people should find out what else is going on with their body and to heal themselves. I think that's the path that I went on. So
yeah, it's definitely has to be part of our journey. It has to be part of this whole care And I mean, endometriosis is definitely an inflammatory condition. So I know Sallie has something to say, so I'm going to mute myself.
Well, I had a question because I don't always get to. We should have more conversations like this, but I don't always get to talk to somebody who does so much with imaging, and I want to take advantage of that. One of my issues with doing, like, when doctors give birth control or they give Lupron without surgical diagnosis, or they tell you, like, you go in bloated, like, how many young women come to me, young people come to me, I'm bloated, my back hurts, and the doctor says pain is normal. One of my issues with that is there's no diagnosis. So as someone who works in doing a lot of non-invasive diagnosis through an MRI, do you feel that this will help that change that landscape a little? Because I can't stand having somebody take something, like, we have a big clubhouse room and the woman is losing her teeth from the Lupron they just left her on for 6 years, and she had no diagnosis yet. Like, I can't stand those stories. Do you feel that advancing these techniques will help stop that, Dr. Haung? Whatever, I'm so not used to.
No, I think that it's a really important conversation that we were also having right before we went live, right? So I'm part of the Society of Abdominal Radiology, and there is a diagnosis focus group for endometriosis. So there is a group of radiologists who's passionate about this condition. At NYU is Nicole Hyman, who has been tremendous. There's no way we would be where we are if I couldn't find a willing partner. And actually at Scottsdale, Jen, Scott Young, a radiologist at Mayo.
Oh yeah.
That man he's a dear friend, but he's fucking phenomenal. I mean, he's just amazing. So he actually does endovaginal ultrasound. So we were talking about MRIs, and yes, it totally works in our center because we have a big academic center. We have amazing imaging technique. We have a group of physicians who are super passionate about this condition, which I think it's, I just lucked out. And it's not always reproducible, although we are certainly having standardized protocols. We have published recently on how to use imaging for surgical planning, as well as medical treatment. But yes, like, we need to figure out what we're dealing with before we actually treat the patient with any modality. So what we've been doing is doing MRI for patients who present with pain. And then if they have, let's say on the MRI shows invasion into the colon, and Dr. Young went and trained with Dr. Abrau's best sonographer in Brazil. And also I went to see, I love this man, Mario Malzoni. He's in Avellino. I went and spent a week with him. I don't know if anyone even knows where Avellino is. It's this small town in Italy, right? Like, basically there's nothing there but him. So I spent a whole week there. And because he also has this team, and his partner would do the ultrasound, and we've seen this live, and he would do the resection, and the measurement is to the millimeter. And that is what Scott Young is able to do as well. Because we actually flew him in from Scottsdale to do a case together, and he found a second lesion that MRI didn't even pick up. And we actually had a hard time finding it in surgery, and he was insistent. So we looked again and we found the second lesion. And what an amazing partnership. Like, if that's what we have and this is what we need, Scott is, blows my mind, but he's also such an amazing individual. I mean, someone who just really cares about the patient, and it is so important. So I don't know if it's replicable right now at scale. Again, we were talking about first world countries, certainly this is doable, but if you're not around a metropolitan area, do you have easy access to these fancy MRI machines? I certainly think that if you were trained well to see this on an endovaginal ultrasound, I mean, people like Scott Young is not exactly everywhere at all, just like one of him. And so we can use endovaginal ultrasound, but people have to be willing to get trained. It has to be interested in this condition. And again, it's like what Sallie said, you know, we have to go the extra step, right? Like Sallie has to go do additional training. I did my minimally invasive GYN surgery training, but I honestly still feel like I did not fully, certainly in residency, I did not fully comprehend the condition. And even after fellowship, maybe year 3 or 4, when I was starting to understand better what the iceberg conversation was about, that if you do not do excision surgery, the reason excision surgery has to be the standard of care is because when you go into the pelvis or the abdomen, all you see is the top of the condition, the top of the endometriosis lesion. And if you just burn or ablate that, you actually will not get all of the tissue underneath. And you really only see 10% at most above the peritoneum. And the depth of invasion is really what correlates way better with your pain than extent of the disease. So you could have superficial endometriosis that's all over. And sometimes people don't have as much pain. And we were talking about this before, right, Sallie? We're talking about if you have superficial endo, and some patients, again, have a lot of pain with superficial endo. And as we get better and better with our diagnostic method, MRI is now 76% accurate. This is 3 years ago. We actually haven't looked at our data in the past 3-4 years. So I assume it's better because we actually come together and the OR, just GYNs bring the OR images and the radiologists bring the MRI images so we can understand better what each other were looking for and what we see versus what they see. Again, it has to be a very close team effort to do this. And I just lucked out. Even finding Nikki, I basically keep wanting her to come back because it was such a great partnership and she truly cares. And, you know, again, anyway, Sallie, I think you were trying to chime in, tell us.
Sallie, I wanted to ask you a question if we can, and actually Nikki could probably chime in here too, but you know, as a person who's suffered from endometriosis for so many years, I'm so curious about the pelvic floor and also breath work, because I find that, I mean, sometimes when I have pain, if I do some deep breathing, and I just got into meditation about a year ago, I can it feels like I'm relaxing those muscles and it does help with the pain. What's your expertise or experience? How can women help themselves in that way?
Well, I think it's important to realize that the pelvic floor and the diaphragm, which is the muscle that helps you breathe, don't work independently. So if we talk about everything as a can, pressure in one area is going to affect pressure in the other. So when you do talk about that breathing helps you relieve your pelvic floor pain, that's actually like a proven thing in the literature. And so for somebody, say, that can't have therapy direct to the pelvic floor because they're too upregulated or they're in too much pain, we do start and we do begin with the breath and we do begin with the ribs and the diaphragm. And so you can access the spasms throughout the floor by using the diaphragm. Does that help answer your question?
Yeah, breathing, right? And that's sort of what the meditation classes were, Nikki, that you were doing?
We did a lot of breath work. In my experience, people have been told a lot to do breath work, but it's not actually described to them how to do it very well. So some people are a little bit tuned out because they've been told so many times, breathe, breathe, but it's not in a really guided way. It's just telling them, you need to breathe, you're too tight. And it's kind of blaming them in all the ways that we're trying to avoid with this holistic spirit. So we did some diaphragmatic breathing techniques, but also for people that have just been told that too many times and didn't want it to be pushed on them by another provider, we did other techniques as well. And mindfulness especially can help you change your relationship to pain. Again, not accepting it as something that you should have to bear as a burden, but to shift and see if you can have a little curiosity, and maybe that can help you change the relationship to it. So that could be even the basic techniques of you're stressed and your shoulders are up here and you're doing a little exercise where you're aware of your body posture and if you actually are breathing in and out, to bring mindfulness to the places in your body that you're sensing the discomfort and seeing if you can notice edges of that discomfort, or you can bring a color to it, or just changing your experience with it, because it's so fraught and it does carry a lot of emotional burden along with it, or you have been pointed to that place in your body by different medical providers and that's all they want to talk about, or it's the thing they don't want to talk about. So just changing the relationship to what you're actually experiencing in your body.
I think Nikki brings up, just as she was saying, she said, practitioners say to people, you're too tight. So now I just said it a second time. Did everybody that's watching, their pelvic floors are now underneath their ears? And I think one of the things that's beautiful about the work that Nikki does, or about what a good physical therapist does, because there are plenty of us that aren't good at what we do, is that we understand that words matter. And the way they're presented to you and the words that they use, especially I feel in the person with endometriosis who has been minimized for so long, words matter. So words matter because it forms your relationship with your body. So I know that you're going to talk about sexual wellness one day, but if somebody is always telling a child, don't touch yourself, you're dirty, well, then guess what? They're never going to enjoy sex. Or what's worse in the endometriosis case is then they think it's because they did something that caused their endometriosis. So words matter. And then on the other side of it is, I love techniques like pelvic PT that may not give a diagnosis, or like mindfulness, meditation, breath work that also may not give a diagnosis, because when somebody gives you a diagnosis, and I do believe there are these other causes of pain. I don't want to say this, but if somebody says to you, you're not okay from your endometriosis surgery because you have pudendal neuralgia, and pudendal neuralgia is real. I'm not saying it isn't, but then for the rest of that person's life or their time in rehab, they can't recover because they have pudendal neuralgia, and their whole world becomes being focused. I have to sit on the chair just right so there's no compression on the nerve, and I can't put my tush on the toilet seat wrong, and I can't this and I can't because I have pudendal neuralgia. And I think that bringing in the breath and bringing in that notion, especially as practitioners, but also at patients, it's okay to say words matter when they're said to me, and I can choose how I interpret them.
I think that's so key. We talk about how pain is unavoidable, but suffering is optional, right? Nikki and
I love that.
So I think so to your point about pudendal neuralgia, I think what does happen is that we then start to identify ourselves with the condition and not understanding that it is just a part of me and not my whole identity. And I think that's a lot of space for us to work on, again, outside of surgery, right? This is not something surgically I can remove in any way, but working in that space of what does this mean to you? What does it mean to you? How do you relate to this diagnosis? Does it become your entire identity? And we can't let it, right? So once you can put words to it, I think it's certainly important to identify what you're dealing with. That's when you identify it, then I feel like you actually can find a way to work with it, but not to then completely identify with the condition. This is just my diagnosis. I am more than endometriosis. I am more than my pain. Yes, I have pain. I've had pain for a long time, but I'm going to learn how to deal with it. But also seeking out medical assistance and understanding not just surgery. I really need to say that one more time. Yes, surgery is important in some cases. It is not always the right answer, nor is it the whole answer, even when it's part of the answer. And we have to really explore this space between the mind and the body. And also, this is why I always recommend acupuncture, nutrition. And this is why Lara Rosenthal, who's a I'm again, another incredible human. And we are going to talk about sexual wellness next month. That's our topic next month, because we want to do these monthly and to, well, again, just educate, I guess, to bring this information, to have this type of conversation, because these are so, I think this is so fruitful just for us to even hear each other, different points of view, and how we all deal with the pain differently, and how that can all come together for the patient. How does it all fit? And it's not all going to be the same plan, right? It's very different. We always ask our patient, what is your primary goal? And sometimes it's fertility, and sometimes it's pain relief, sometimes it's both. And I think there's what we classify, there's always trauma, big T, little t, but there is trauma with this condition. Even if you did not suffer a sexual trauma, there is a high percentage of patients with pelvic pain that has a history of sexual trauma. But that aside, the condition itself is a bit traumatic, considering if you've been in pain for a long time and have not been validated by anyone, including your parents, including your practitioner, healthcare practitioner, whoever you're seeing, either a pediatrician, gynecologist, or primary care doctor, who hasn't validated your pain or who hasn't heard that your pain is real, that's just trauma in its own. And then there's so much about fertility with endometriosis. Patients are asking, should they go freeze their eggs in their 20s? I mean, there's just so much anxiety around the condition that I think if the more, and there's so much shame, and I'm trying to understand, I guess, in a way that the reason we actually started the weekly meditation, yes, is for the meditation. And Nikki and I were talking about this, but mainly it was also just to have a connection for you to understand that you are absolutely not alone. We are all interconnected in some way. And I'll say that when I have fibroids and I had to undergo surgery. And as a person who does this for a living, I felt very alone, which made no sense. But obviously, academically, I know a huge amount of population has fibroids and suffer from this condition. And even then I felt like I was the only person suffering, which obviously made no sense. And I reached out to Nikki because I was undergoing surgery myself and I was just a mess. And I had to, I did every single meditation I knew. And then I just like, why am I not reaching out to Nikki? I have asked her to help with our patients. And in this moment, I'm not a practitioner. In this moment, I'm just a patient myself. And it was incredibly helpful to I think when you're courageous enough to admit your vulnerabilities, that shame goes away a little bit, not all of it. I mean, so it was a deeply personal experience for me. So what I say, I want to not just double down on this type of network. I want to triple down on what we can do that surrounds surgery. Maybe surgery is a key point, but to me, it's not even the main point. Like, how are we going to help you accessing all the information we know? And that includes nutrition, that includes emotional wellness, that includes mental health, right? Includes meditation, includes pelvic floor PT. How do we help you? And we don't know yet what the answer is, but we're going to work together and find it for you, and whatever that plan needs to be. So I'm also mindful that it's now 6:51. I think we need to answer some questions because we're going to suppose to end at 7. But let me look at the Q&A session.
Can I just say something while you're, and then you can do Q&A while you can filter the Q&A while I speak quickly. Okay. So I also think, and I want to acknowledge that it's very much a privilege for someone with endometriosis to have a multidisciplinary team. And unfortunately, that's not the picture for most of the people in the US or the world. So I want to say thank you very much to NYU Langone, because even if someone can't access, I mean, I do it for the Endometriosis Summit, but even if someone can't access this multidisciplinary care, if they can have access to a computer, they can hear these webinars and change can begin to happen. So I just wanted to acknowledge that for you guys.
I think the emotional aspect of all of this is your third webinar, because there's so much to unpack there, right?
I know.
could do a whole, and by the way, trauma, capital T.
Yeah, there's such
and there's the statistics there.
Yeah.
There's a lot to unpack, and there's more to learn on the mindfulness and the meditation around all the emotional aspect of this. So thank you. Yeah. We have a bunch of questions now.
Yeah, anyway, you're right. That's going to be our third webinar. So Gabby, thank you. Gabby has a question for Sallie and Jen. Gabby is our star resident who's going to be part of our next webinar when we talk about sexual wellness. So I'm just going to tell you now, her question is, Sallie and Jen, what would you tell our OBGYN training regarding how to approach patients who endorse pain? What did you find most helpful? To Sallie.
So I believe very strongly that the first place to start is to listen. And if you're listening to your patients, you're going to provide them a space that many haven't. And so I always say start there, but I also say that sometimes education comes outside your residency. The Endometriosis Summit has a fellowship, so certainly applying for the fellowship. I'm sure NYU's program has fellowships too that you can go into advanced causes of pain. But I think educating yourself on what pain is, and a lot of that literature is outside of OBGYN world, whether it's in physiatry, whether it's in reading all of Maurice Chung's work, whether it's attending a conference like IPPS or even SLS, a little more than just a surgical conference. Some of the ways urologists approach pelvic pain is very different than how a gynecologist approaches pain. And like Kathy said, and also the PTs actually, it's open to everyone. I believe the webinars that something called pelvicguru.com offers through their GFAM membership, you can take an hour of different causes of pelvic pain, like every night for a month, and learn more than I learned in PT school. But I also think Kathy hit the nail on the head in that it's also an iceberg of learning. And how many years post fellowship, and you come from one of the best fellowships in the country, did it take you to get this whole picture?
It took a long time. And then I think we have to be willing to cross some boundaries. I always feel like we're a bit siloed. And I'm always trying to figure out how do we work with other specialties to understand not just endometriosis, but any of our conditions better. Jen, did you have any advice for Gabby who's?
Yeah, two ideas. I mean, I consider myself an outspoken person, but I find myself one-on-one with a doctor in the room, and I'm not going to tell the doctor willingly, I have so much pain that I'm vomiting in the middle of the night. So asking questions, how does your pain affect your life? Does your pain inhibit your ability to go to work? Like understanding where I am, because I think I have pain and then I get a nod like, yeah, we know women have pain, and then it moves on. And I, even as an outspoken person, never felt like I could really express like, no, you don't understand, I have pain. And especially when I was younger in my 20s and early 30s, that never really got out there. And the second is just resources. I'm a former journalist, and I'm on the internet on Friday nights reading about endometriosis. And I have probably a whole shelf in my bookshelf about period pain and all these things. But having recommendations for meditation and breath work or all the resources, things to read so that patients can educate themselves and start to go on their own path and own journey, any way to kind of jumpstart that. Because, I found Kathy from heavy internet research. The more that's out there, if more OBGYNs were talking about it in a way and promoting each other and talking about working across, disciplines, I think the more community we can build. So those are my tips. I haven't had a doctor like Kathy before who offered resources like this, and I'm so grateful.
So Kathy, at NYU, the last, Dr. Scott Young was there when we did it. You had an anesthesiologist that studied pain and also did yoga. But if it's your resident, I've talked to that guy like 500 times on the phone. I'm sorry, I can't remember his name, but that's an excellent resource because he could explain the mechanisms of pain wonderfully. So I think a resident should go hunt down, even if it means going to anesthesia, and go have a cup of coffee, go learn what you can learn.
So I would say I mean, I ask anesthesia all sorts of questions. Like, I want to understand, why do we pre-inject, all that stuff. But, I would say 2 months ago, a reporter asked me, was doing a story on endometriosis, and she was asking me what I wanted to tell patients, like, how do they bring this up? And I said, that's too much. Why are we putting the onus on the patient to bring up their pain? It needs to be doctors who give you the space to talk about your pain. I need to ask you, right? Gabby is doing this already. Gabby and I are working on a sexual trauma survey, because we need to ask you, not you need to tell me, right? So we have to make it normal. We have to give you it is our job to make you comfortable, so you're willing to share a very vulnerable part of you with me, not your job to show up, because I have to make you feel like you can trust me enough that I'm going to be courageous enough to stand in your pain. Right. And then so I don't think it's your job to do that. It's really our job. And that's why Gabby is asking these questions. So I think that's a great question. Wait, there are lots of other questions, I'm being told. So I need to go scroll through more questions.
I think the last one Michelle asked us to take a look at, or asked you to take a look at.
Okay. What kind of MRI is used to look for endometriosis? Okay. So I can't describe the exact protocol for the MRI, but certainly we can. I don't know how to send this out, but actually we will send this. We'll have to figure out how to send out this information, but maybe another session could be with our radiologist. It's not just the technique of the MRI, it's also how they read it. So there's a special dye, it's a diffusion weighted, and we need IV dye, contrast, T2 weighted images, like that gets way too technical for me to explain. But again, it needs to be a partnership between the radiologist and the gynecologist, so that we can actually get to the better part of the answer. And we do continual learning. Again, we meet on a regular basis to go over the MRI images as well as operative images, so that we continue to improve on our diagnostic accuracy. There's a question, Sallie, that you mentioned your organs were removed without permission. How does this happen? I don't know.
First of all, I'm not sure that's the purpose of the webinar, but when you sign a consent for surgery, it's like, basically, if you die, we're going to do this. If this happens, we're going to do this. And honest to God, the guy just handed it to me and I signed it. There was no going over it. There was no mentioning, I'm going to take the ovary, I'm going to take the tube, I'm going to do this, I'm going to do that. And I woke up with that, with no warning. And I also woke up to a posterior uterine reconstruction, which saved my pain levels from adenomyosis. But as you know, my work with Antonio Gargiulo has really solidified that I would never have been able to carry a child after you have a posterior uterine reconstruction. So all of this was done without that. Kathy Haung would never do this. She was not my surgeon, but all of this, because I know you well enough, all of this was done without my consent. It's not. And then the kicker, my favorite part is, it didn't even treat the cause of pain, because the cause of pain was a huge inguinal hernia that wasn't being read properly on the MRI. And that's its own discussion on why we can't read that for women with pelvic pain. We can't read those MRIs correctly in terms of finding hernia, but it does happen. And I'm not the only one. I've talked to people who have had uterus removed without consent. So you sign a generalized consent form, it covers the behinds of the hospital, but it isn't the same as what's known as informed consent, which is sitting down with the patient and discussing what's going to happen and why something needs to happen and why something may not happen. So that's that,
So one more thing to go over. Jen, do you want to speak about the anti-inflammatory diet? Because I think you'll probably...
I do. Sarah asked that question. I hope Sarah's still here. I mean, this is this is my experience, but I started an anti-inflammatory diet is a whole foods diet. It means not eating things that come in a package. By and large, that's a simple way to explain it. I'm not a nutritionist, by the way. This is not medical advice. This is my understanding as a patient. I started with a program called Whole30, which you guys, it's taken, you know, the world by storm. It's a great place to start. If you have a diet that has a lot of processed and packaged foods in it, it kind of weans you off of things that could be causing sugar causes inflammation, for example, alcohol because of the sugar. I would say that for me, managing my blood sugar and eating things where I can maintain a steady low blood sugar has reduced the inflammation in my body. And I know that through testing. So eating fruits and vegetables, emphasis on the vegetables, not the fruit. Eating meat, eating, you know, some people can tolerate dairy, some people can't, but, you know, toss the cookies and the ice cream is a great way to start. I also lost 20 pounds, by the way, where I had been struggling counting calories, never counted a calorie, and just focused on whole natural foods, reduced my inflammation. I could actually see the inflammation go down in my face. Like I look like a thinner person. So I would say start with a whole foods diet. And you can Google anti-inflammatory diet and read, you know, there's a lot of stuff out there. Mark Hyman is a big advocate of whole foods, anti-inflammatory diets. He's an amazing resource. Somebody else asked about functional medicine. And I think, Kathy, they asked for you if you had a partner, but I mean, I would look at Mark Hyman's Institute, right? And just his podcast and get educated.
Yeah. So I actually would say for people with endometriosis, which a lot of us are here tonight, if you're looking for information on diet and anti-inflammatory approaches and how to optimize your system, Jessica Drummond is a functional nutritionist who owns Integrative Women's Health Institute. And on Integrative Women's Health Institute.com, there is a free download to her book, Outsmarting Endometriosis, which describes a very specific anti-inflammatory approach for those with endometriosis and pelvic pain. And the hard copy is available in Barnes and Nobles, but if you Instagram her because you can't find the link or whatever, she will give you the link to the free digital download of the book. And I reviewed the book. I think it's a great book, and it really could be a good roadmap for people listening tonight.
So I would just say, close it out by the doctor I do work with a lot is Lara Rosenthal, and she is a traditional Chinese medicine doctor as well as acupuncture, and she has made a lot of, I mean, I see her every Friday myself. That's been instrumental in my life. And I've made some dietary changes because I'm kind of lazy about that. But lifestyle changes, and she's taught me so much about diet and whole food versus processed food. So there's a lot of information on her website as well as Lara Rosenthal. Okay, so we need to close out because it's already 7:05. I want to thank everybody who joined us, and a huge thank you to our panelists. This has been an amazing conversation for our very first endometriosis webinar. I hope you guys can turn in next time when we talk about sexual wellness, because that's another topic that's so key to our conversation. A huge thank you, guys. Thank you so much.
Thank you.
Here.